Good morning, everyone. I'm Leanne Griffin, and on behalf of the Florida Alcohol and Drug Abuse Association, welcome to today's webinar entitled Recovery-Oriented Systems of Care Organizational Assessment. This webinar is being made available through a collaboration of the Florida Department of Children and Families Office of Substance Abuse and Mental Health and the Florida Alcohol and Drug Abuse Association. Before we get started, let's go over a couple of technical details. Please note that as an attendee, you are in listen-only mode and will only be able to view your name. If you have questions, please send them to the presenter and myself, I'm the host, by using the Q&A panel. The button to open the panel is usually located on the upper right side of your monitor. Please use the Q&A panel to send any questions you may have as you think of them. The presenter will answer questions at the end of the presentation. Our audio is being broadcast through the internet to your computer. You must have speakers attached to your computer and have the correct software and the volume on. If you experience poor computer audio, there are a few options to try on screen right now, and we'll post these in the chat box as well. But of course, you may always join the webinar and call in using the telephone option, I will call in. And you'll see the telephone number posted for calling in if you do choose to join us through the telephone. The recording and materials used in today's presentation will be available on the FATA website within 5 business days. To access the recording, go to www.fata.org. Also, a PDF version of this PowerPoint presentation will be emailed to participants within 5 business days. Continuing education credits are available for participating in today's webinar for persons licensed through the Board of Nursing, the Board of Clinical Social Work, Marriage and Family Therapy, and Mental Health Counseling, and also for persons credentialed through the Florida Certification Board. At the event's conclusion, the web browser will direct participants to an evaluation form on the FATA website. If you would like to receive continuing education credits or your certificate of attendance for this event, you must complete the evaluation. Be sure to include any Florida license number, if applicable, for reporting to CE Broker, along with the prefix for your license number. Your certificate of attendance will be delivered to your email address within 5 business days. Do please note that WebEx monitors arrival and departure of attendees and provides a report upon completion of the event. This attendance log and the evaluation forms are used to validate the provision of contact hours or the certificates of attendance. We are not permitted to provide contact hours or a certificate of attendance if you do not attend the entire webinar, and we are not permitted to provide partial credit. I'd like to introduce our presenter for today's webinar. James Winarski, MSW, is Faculty Research Associate at the Department of Law and Policy, Louis de la Parte, Florida Mental Health Institute at the University of South Florida. There, Jim provides technical assistance and training in the areas of assessment, development, and implementation of behavioral health programs. He has worked in areas of mental health, substance abuse policy, and program development at federal and state levels, with a special focus on mental health recovery, rehabilitation programming, and issues related to homelessness. Jim recently completed a study of recovery-oriented services for Florida's Medicaid Authority, that's the Agency for Healthcare Administration, and developed an assessment and planning tool to support the delivery of recovery-oriented services. That assessment tool is being used as the guiding framework to support Florida's statewide recovery-oriented systems of care initiative. Jim earned his master's in social work at State University of New York at Buffalo, and we're very pleased to have Jim join us today. And I'll be turning over control of the presentation in just a moment. Jim, are you ready? I'm going to be passing control of the presentation to you. And Jim, make sure your telephone is off mute. Jim, can you hear me? Make sure your phone is off mute. We'll be having Jim join us again momentarily. Jim, let us know when you're on the line. Louise, are you on the line?
Yes, I am.
Can you hear me okay?
Yes.
Good. Just making sure. I've got Jim dialing back in.
Are you hearing me?
Yes, Jim, hey, I'm glad you were able to join on. We're just a few minutes late, but just 10 minutes, so I think we'll be okay. Are you ready? I'm going to pass control over to you.
Okay, I re-signed on, so, okay, I see your thing coming on, and we'll make sure that's working. Okay, we're good.
Great. So whenever you're ready.
Okay, we're ready to go. Well, thank you. Again, sorry for the delay. Welcome, everyone. Again, my name is Jim Winarski, and I'm coming to you from Tampa, Florida at the University of South Florida. Delighted to be with you. And today's webinar, we're going to be providing an orientation to the self-assessment planning tool for implementing recovery-oriented mental health services, or the SAPT. And specifically, the tool as it's been adapted for Florida's Recovery-Oriented System of Care Initiative, or the ROSC, and we'll be referring to ROSC throughout our presentation. So for today, we'll be discussing the tool's 50-item survey and the planning and implementation guide goes with that, as well as issues that are critical to implementing effective recovery-oriented services. The tool is designed to assist service provider agencies in establishing policies and practices that support a process of recovery for persons with serious behavioral health disorders. The ultimate goal is to make recovery a living reality in Florida's behavioral health program systems and communities, and pretty much consistent with what we're trying to accomplish with the ROSC initiative. Okay, our objectives today specifically will be describing the domains and survey components in this assessment tool. We'll be describing how the self-assessment supports the ROSC initiative and looking at specific instructions for implementing the tool. In addition, I'll spend some time describing why recovery and the vision of ROSC is vitally important to our field. The why of this is actually really critical, before we move forward with implementation. After describing the tool, I'll also discuss some lessons learned from our pilot studies and from years of implementing these kinds of practices. So I will be going into some detail regarding both recovery and the tool, but as we start, there's two main things to keep in mind. That when we talk about recovery, very simply, it's rooted in the realization that persons diagnosed with behavioral health conditions are human beings. They have the same wants and needs that we all share. Our programs and our systems haven't always respected that, so that's really what this is about. Another important point is when we look at program tools, and this is true of any tool, they are only as good as our commitment to achieving excellence, to achieving the vision that we're trying to work towards. So, if we go through the motions, we get status quo, but however, I think if we're committed, the tool gives us a structure and a process. It empowers us really to achieve excellence, and in that regard, the sky is the limit. Okay, talk a little bit about ROSC, which is a values-driven approach to structuring behavioral health care systems and a network of both clinical and non-clinical supports. In that regard, the state of Florida, under DCF leadership, and specifically under Wes Evans, who I must say has just done a marvelous job of putting all these pieces together throughout the state and leading a variety of meetings and assessments that have really got us on track, I think, to do some very special things here in Florida. But that's been conducted as part of a national initiative that's supported under SAMHSA, the Substance Abuse Mental Health Services Administration. And I see it really as a natural evolution of findings that came from President Bush's New Freedom Commission back in 2003, and that was the first major federal policy change in over 25 years. And in that policy, they identify recovery as the key to system transformation. So specifically for the ROSC initiative in Florida, there were 10 summits facilitated as part of that process. More than 1,100 people attended events throughout the state. Summits were held in all regions of the state from September 2016 through January of this year, and they were followed by an analysis and strategic planning in the spring and summer of this year. So I was very delighted to be part of that planning during the past year in the Policy Academy as we now move forward with implementation. And that's really where the tool comes in. So as part of these meetings, we developed a shared vision, we identified priorities, and we mapped plans for regional and statewide approaches. And also, more recently, there have been regional peer specialists who have been hired to lead system coordination activities as we begin to define roles and responsibilities for all of our community stakeholders. So the SAPT tool is really designed to help guide these kinds of activities. Okay, I want to pose a question. The question is it safer to be helpless than it is to be hopeless? And this is a question that was posed by Dr. Pat Deegan, who is a nationally recognized clinical psychologist, a researcher, advocate, who speaks and writes eloquently about the importance of hope and the devastating consequences of losing hope for people with serious mental health disorders. She points out that hopelessness and the corresponding experience of powerlessness can all but crush the potential for recovery. So if a person feels that all actions are futile, no control over the environment, attempts to improve seem to fail, there's a loss of decision-making in key areas of life, the power in your life really rests in somebody else's hands. These are all things that are prescriptions for hopelessness. And the unfortunate reality is that often our programs and systems, even with the best of intentions, can contribute to this experience of hopelessness and powerlessness. And to that, in relation to that, I'd like to share with you a quote from Dr. Deegan describing this, and I think this is something that might be familiar to all of you, and this is it. Okay, when those of us with psychiatric disabilities come to believe that all of our efforts are futile, when we experience that we have no control over our environment, when nothing we do seems to matter or to make the situation better, when we follow the treatment team's instructions and achieve their treatment goals for us, and still no placement comes open for us in the community. When we try one medication after another, after another, after another, none of them seems to be of any help. When we find that staff do not listen to us and they make all of the major decisions for us, when staff decide where we live, with whom we live, under what rules we will live, how we will spend our money, if we will be allowed to spend our money, when we will leave the group home, at what time we will be allowed back into it, et cetera, et cetera, et cetera. Then a deep sense of hopelessness, of despair begins to settle over the human heart. And in an effort to avoid the biologically disastrous effects of profound hopelessness, people with psychiatric disabilities do what other people do. We grow hard of heart, attempt to stop caring. It's safer to become helpless than it is to become hopeless. And she goes on to say that giving up was not a problem. It was a solution. It was a solution because it protected me from wanting anything. If I didn't want anything, then it couldn't be taken away. If I didn't try, then I wouldn't have to undergo another failure. If I didn't care, then nothing could hurt me again. My heart became hardened. So, this experience, often repeated in our programs and systems, these things are not a function of illness or addiction, but rather a failure on our part to believe in the potential for improvement and to trust the people we serve to get behind the wheel and be the driver on that journey of recovery. Really, and the bottom line is without hope, we have no recovery. And that is why when we look at the central vision of ROSC, and really of the whole recovery process, it's really a vision of hope. So there's that hope that disturbing symptoms can be overcome, hope to become a meaningful participant in community, hope in the possibility of a life fully lived. So in the recovery vision, the integrity of the person is paramount. Mental illnesses and addictions and the symptoms associated with them pose challenges to the person, but they do not define the person. And specifically, when we look at ROSC and the vision that was articulated, and this is a vision statement that was developed as part of the Policy Academy and the Planning Committee. It's to establish an integrated, values-based, recovery-oriented system of care where recovery is expected and achieved through meaningful partnerships and shared decision-making with individuals, communities, and systems. So we were all real proud of that statement. I think it really captures the essence of what we want to do, especially the fact that we're dealing not just with our programs and systems, but we're looking at ROSC at bringing in the entire community as part of this process of transformation. So the self-assessment planning tool we'll be talking about today is really designed to develop practical strategies to realize this vision. ROSC in Florida, really the focus is on the importance of transforming the culture and the practices of our systems of care to a recovery orientation. Now, I know that making changes in program culture can seem like a daunting task, and that's something culture can be difficult to get a handle on, but in reality, changing culture is really about changing performance. And I know when I researched this, and most of the research, or most of the literature on this, you'll find more in the business world. But you see again and again, it's really about performance. And changing performance isn't easy, but really if you have a compelling vision and you have a clear map, it is quite achievable. So over time, recovery orientation really should become our routine, and that's when we'll know we've really made that change. Okay, and I also wanted to share with you some ROSC references, and sorry I missed the introduction on this and my audio cut out, but I presume that you'll be able to get access to these links on this PowerPoint after the presentation, but they include work by Ajoma Achara, who was the national consultant who worked with us in the Policy Academy here in Florida. Includes a white paper of the work we did, as well as her peer support toolkit. The Florida Google ROSC Google Drive folder has all of the working documents from that committee. There's also a YouTube video that was produced by DCF, which is excellent. That really captures the heart of what ROSC's about. There's a Dana Fogel song from Magellan, who is a very important member of our committee, has a document on recovery and systems of care. There's a report from SAMHSA that provided guidance. There's a link to the Peer Support Coalition of Florida, led by Cameron Wood, who was also on our committee, and also to documents of earlier iterations of the planning tool that were used, that were later adapted for the ROSC program. So I point you to those, and I'll point you to some other references. I think that's all of them. That's correct. And I'll point you, there are some other resources as part of the tool that will be available to you. Okay, now moving on to the tool itself. And the SAPT was developed by a team of faculty here at USF, people with lived experience of mental illness who participated, as well as service providers, agencies. And it was done here at USF at the Florida Mental Health Institute, and was done under contract to our Medicaid authority, AHCA. Now the relationship of ROSC and the SAPT, essentially the ROSC adaptation of the SAPT occurred about 5 years after the tool was originally published in 2011. So We revised it specific to the needs of ROSC, and the revision was done under contract to the South Florida Behavioral Health Network with financial support from Magellan Complete Care. So we express our appreciation to them for their support. So now as we go forward, when we're looking at moving from more traditional and limiting views about mental illness and addiction to a recovery vision, it requires clear articulation of supportive policies and practices to make that happen. So the SAPT is really designed to help behavioral health agencies translate that recovery vision into effective policies and practices. So it's designed, one, to operationalize that vision, assist provider agencies with a process to monitor, improve performance in implementing services, and also to suggest options for how you enhance service delivery. And that comes through the Planning and Implementation Guide, which is an important feature in this tool. So why recovery services? I think it's, again, as I mentioned earlier, the why is very important in terms of being the driver for what we're doing. The bottom line is that the hopeful and empowering vision we see with recovery, unfortunately, it's contrary to assumptions that have shaped mental health, especially mental health policy and practice for the past half century. So, according to general assumptions, we still see in the field today, mental illnesses follow a course of long-term deterioration in symptoms and functioning, and that inevitably limits meaningful participation in community life, leads to reduced expectations about potential persons with mental illnesses. In many ways, little hope has been offered that the person could achieve a vital and satisfying life. Consumers of mental health services often felt diminished and demoralized by the very system that was designed to help them. Now, in addition, and I alluded to this earlier, President Bush's New Freedom Commission, and in their report, Achieving the Promise, they concluded their work in 2003 and produced the first major policy initiative that we've seen since 1979, at least at the federal level. And after an extensive analysis of program and systems throughout the country, they determined that and really assessed our mental health system as, quote, fragmented and in disarray, leading to unnecessary and costly disability, homelessness, school failures, and incarceration. And now it's hard to believe, now it's almost 14 years later, but I'd say the assessment would still hold true for the most part throughout our systems. And importantly, they recommended in the commission, and this is what's important for us, that we fundamentally transform service delivery based on a recovery vision. So recovery is the centerpiece, it's the linchpin of federal policy. And in fact, recovery-oriented initiatives, we're moving forward until really the financial collapse of 2008, where, as we all know, behavioral health budgets took some pretty serious blows, but still recovery remains very much alive, and the ROSC initiative bears witness to that. So but the outstanding work that was done by this commission and its various work groups remains as relevant today as the day it was released. It's still a very valuable kind of touchstone for us as we move forward. Also wanted to, when we look at the kind of some of the background, that in the ROSC initiative, there was an environmental scan that was conducted in 2016 as part of the Policy Academy, and they determined that there was a lack of integrating peers into meaningful roles, especially in advisory and leadership capacities, and that there was a lack of connecting individuals with non-mental health activities and community inclusion. So we have a lot of, we have some specific data that we've just collected throughout the state that I think tells us that there are, specific directions we can move in to make a difference. Also, as I mentioned earlier, the SAPT was developed really originally under contract to AHCA, and it included a two-part study that examined recovery and rehabilitation services throughout Florida, looking at both implementation and the readiness of the system to kind of move forward. The studies we had a series of interviews, focus groups with consumer service provider organizations, clinicians, representatives from managed care organizations. So we tried to get a broad picture of, where the system was and what it would take to kind of move it forward. And it was based on the new coverage and limitations handbook that was issued at the time. And we found that there was a period of transition where consumers and staff were defining new roles and responsibilities. I think that's true today. And what's really important here is that when we're talking about these changes, we're not just talking about our staff, we're not just talking about our programs, but we're talking about the people who are our service recipients who also, in a recovery orientation, have a different role and responsibility, and that they need to get behind the wheel and drive their own process. And it becomes incumbent upon us to determine how we help them to get behind the wheel. So there are different significant shifts in roles and responsibilities that are required to move forward. We found a lack of tools to support the transition, which is why we developed the SAPT. We found there was no way to ensure that the services described in the handbook were really being delivered at an acceptable level. We found that individuals didn't experience program activities as relevant to achieving life goals. So there was not a connection necessarily between the treatment plan and where it was going. Sometimes that might have been specified in the treatment plans, but when you speak to the persons who were the consumers or the service recipients, didn't see that connection often. Individuals often experience treatment planning as bureaucratic rather than an interpersonal process. We found staff perspectives on recovery principles and practices vary considerably across individuals, where we had some staff entirely supportive and fully engaged in, and supportive of a recovery orientation. Others really saw it as a prescription for failure, as raising false expectations for people, taking us down a dangerous path. So I think that's something we have to be cognizant of, is that there is a range of perspectives that exist at multiple levels throughout programs and systems. Florida has a range of disparate service activities that are recovery-oriented, but there's currently no framework to guide it. And I think that's changed now. And we look at ROSC, and the whole idea of this tool is to get frameworks in order so that all of us can get on the same page. And importantly, finally, we found that really a handbook, important as it is only a first step in supporting effective implementation. So, billing codes are very useful, but it's not enough to really support effective services. Okay, I want to talk a little bit about the pilot of this tool, because it was done here in Florida, and I think it gave us confidence that this is something that is useful and can really be truly supportive of a good recovery-oriented program and system. So there were, and this is really developed in response to the findings I just described. To move forward, there were 11 mental health agencies that participated in a two-phase pilot. The first part conducted an item analysis as part of a process of revising the survey, collecting feedback on the efficacy of the tool. We originally started, I think we had about 85 to 90 items that we eventually kind of whittled down to the 50 that we have right now. And we also tested a web-based method for data collection. I'll talk a little bit about that later. I won't go into it in too much detail, but it's something I want you to know about as an option that's out there that might be helpful. In the second phase, examine the relationship between the SAPT tool and the Recovery-Oriented System Indicator, or the ROSC. The ROSC is an outcome instrument that's based from a consumer or service recipient perspective. And we based the development of this program tool on an item analysis of, or factor analysis of the ROSC. So the idea is that we want the SAPT to produce better outcomes. And indeed, we did find in the pilot that agencies, if you have a higher SAPT score, you tend to have a higher ROSC score. So in other words, improvement in the factors in the SAPT is connected to recovery-oriented outcomes. And all of these pilots and studies are all available on the SAPT website, which I'll show you a link to in a moment. And I just wanted to also share with you the agencies that participated, and mainly because I want to express my appreciation to all of them who volunteered to participate. This was all entirely volunteer, and all of them deserve great credit, and they all demonstrated a passion for making the recovery vision a reality. So I know there's many of us out there that want to see that happen. So these are the agencies in the first phase and agencies that worked and volunteered with the instruments in the second. And again, our thanks to them. Okay, now we're going to move into the tool itself. We'll look at how it's organized, and we'll do a little walkthrough about kind of how you would use this to actually, kind of get a baseline of your recovery services functioning. So both the survey that's part of this tool and the planning and implementation guide are organized under three primary domains that were derived from the factor analysis I mentioned earlier with the ROSC. They include administrative, treatment, and community integration. And each of these three main domains has subdomains as well. The administrative has 5, treatment has 5, and community integration has 4. So in sum, there are 3 primary domains, and there are 14 subdomains, and there are 50 items in the survey that really are related to each of those domains. So, and each of these areas, each of those domains and subdomains are described in detail in the planning and implementation guide that's on page 15 of the tool. So both the domains, the subdomains, the survey, and the planning and implementation guide in the tool all are organized around this framework. So these are the administrative domains that focus on recovery orientation of agency management and operations, policies and practices. So they include philosophy, continuous quality improvement, or CQI. That's a very important component. Outcome assessment, staff support, and consumer and family support. And there are 12 survey items that assess these domains, and they are critical to supporting effective services implementation. And that's supported by our best understanding of the implementation science, because it's not uncommon in our field to see this view that as training as a method to enhance clinical performance. But the reality is that without a corresponding administrative and supervisory support we can expect a transfer rate to performance from that training of about 10%. Not very good. And yet it's something we still continue to do. And I'm reminded of a colleague who used to refer to this as the spray and pray method, kind of put the information out there and kind of hope it sticks somehow or pray that it sticks. And really there needs to be more. So it's the same as, you know, as I refer to with billing codes, we're focusing only on training and the clinical operation, as important as that is. It's an important component, but it's not enough. So administrative supports and supervisory supports are absolutely vital to success. Okay, the next set are treatment domains, and they focus on policies and practices at agencies that support recovery-oriented treatment. And they're addressed by 21 items in the survey, and they include validation of the person, person-centered decision-making, self-care and wellness, advanced directives, and alternatives to coercive treatment. And again, each of these are described in detail in the Planning and Implementation Guide. And the third main set domain is community integration. And they focus on policies and practices that support service recipients with regaining meaningful roles in community. And they are addressed by 17 items in the survey, and that includes, access to services, basic life resources, achieving meaningful activities and roles, and peer leadership. Okay, so now we're coming to the three main components in the tool, and this is kind of the nuts and bolts section of the presentation. So we're going to look at the SAPT survey. We'll look a little specifically at what's inside the Planning and Implementation Guide, how that's set up, and we'll explore how this tool is linked to consumer outcomes. We'll talk a little bit about each. Okay, so when we look at the survey, as I mentioned, there are 50 items. It uses a 4-point Likert scale, and that ranges from strongly agree to moderately disagree to strongly agree on the scale. And the survey respondents, the design of this is that it should include key administrative staff, clinical supervisors, and select clinical staff. And we're going to talk about that in a little more detail in a moment. There's also a software application that could be used to develop these surveys and host them and so forth. I'm not going to go into detail. We use the Qualtrics program. I will highlight, though, that there are things out there. However, you can use Excel. You could do it manually. There are many different ways, and depending on how much you're collecting, it would determine what kind of method you might want to use. But it's not all that complicated, but there are different methods out there available. So as far as selecting our staff, we want people from administrative levels involved, clinical as well as direct service folks, but staff should know how agencies are delivered in specific programs, and that's really the key, is that we want people involved in the survey who really have a depth of knowledge. Some folks at the agency level who are, more at administrative capacities, and also people in specific programs, because as we'll see, we're going to want to look at not only the overall agency, but also specific programs within agency, which really helps us get a better handle on the level of recovery orientation. So in the survey, we'll collect information from staff in each program, and ideally we do this at 6 to 12-month intervals. I think in the beginning especially, I'd highly recommend doing it at 6-month intervals until things we get on track. as I mentioned, we can use manual or web-based. We talked about that, and there's actually more detailed scoring instructions right in the tool on page 7. That, in fact, the tool has everything you need to proceed. Sure we're working there. Okay, there we go. So in scoring the survey, we examine the scores for each domain, for each program, and we combine scores of programs to establish a baseline of strengths and weaknesses. And that's essentially what we're doing with this. So we're looking at it gives us a picture for each program. We can actually, for each of those main domains I talked about, we get a score that gives us a baseline of where we are and where we need to go, both the agency and the program level. So for interpretation, the findings are designed to provide a point of reference for conversation and strategic thinking. This is a really important point because the quantitative part, the numbers are not so important. I mean, they're important in the degree that they give us a relative picture of kind of where we are relative to what's ideal. And it gives us a baseline that allows us to kind of track how we're making progress. But in the end, the real value of this is in how we use this tool to stimulate conversations in our program and to actually use that information to think about how we're going to get better and to think strategically about the best way to do that. So important to recognize also it's a self-report instrument. So this isn't an objective analysis of performance. Now, we could take it in that direction. We'll talk a little bit about that, but at this point, we're really looking at it's a self-report, and it's really a program improvement tool. It's a quality improvement tool. And it's only as good as I said earlier about the commitment we have to realizing the vision and making sure that we want to use this to get better. And this provides the structure and process that allows us to do that. So, you know, it's all about having honest conversations from a variety of perspectives, and ideally including service recipients as well to inform that process of strategic planning and continuous quality improvement. So what's really important is that the survey needs to be integrated into standard quality improvement activities, meaning that there's a person who is tasked with the responsibility for tracking the progress of recovery orientation as part of routine CQI practice. So, you know, basically you've got to have a person who has a role and a responsibility that's specific to this tool, that's specific to recovery orientation, and ideally make that part of your standard quality improvement practice. So it's something that you can integrate into how you do business. And that allows you to compare findings to objective evidence also, if you wish, look as things like policy statements and clinical records, and even observations of practices if you want to take it to the next level of a more kind of formal evaluation. It does provide a foundation for doing that. Okay, so that's the survey. And I think without having it in hand, I know it's I'm kind of asking you to kind of imagine it, but I think I'll refer you to the website where you'd be able to download this material and also look at the, there's a link for the web-based survey that has all these items. You'll be able to get a direct look at them. Okay, so now for the next segment, the major segment is the planning and implementation guide. And this is designed to serve as a reference for staff in developing your plans and implementation strategies. So it's kind of a support document, and it clarifies terms and practices that define recovery orientation. Now, I strongly suggest that you read this guide before you begin the survey process and before you do the planning process, because it provides a good orientation to the nuts and bolts of recovery services implementation. And it also relates specifically to each of the areas covered in the survey. So it really will help you in understanding how to use the survey more effectively. It will also support you in having informed discussions specific to your planning and your quality improvement. So it's a very important feature of this tool, and we thought it was very important to get clarity on a lot of the concepts, and we'll talk in more detail about how we try to achieve that with the guide. So, again, it's looking at practical guidance, and it also includes resource references, which we'll talk about. Okay, so the guide is set up first to provide a description. So that's a clear definition of the domain, and it explains why it's important for implementing recovery-oriented services. Having a clear definition addresses some of the confusion that has sometimes surrounded the implementation of recovery-oriented services. Some of these, when we're looking at recovery, often what people have a hard time with when we look at definitions is we're talking not about just objective observation, but there's such a heavy focus on the client's experience, their own perception of what they want, how they achieve goals, and each recovery journey is so different. Each individual is so different. So sometimes that can create some confusion around definitions as it relates to recovery. So we try to, with our descriptions here, to ensure that we have a sharp focus. It describes essential characteristics, a brief summary of the most important service components, including a description of activities needed for capably implementing those components. It describes barriers, some of the most common barriers for each of the domains, that are often encountered in trying to implement these services, and steps that you can take. And it looks at remedies, suggests strategies for overcoming each of those barriers. And finally, it provides resources, a reference to key resources such as articles, manuals, websites that can assist agencies with program planning and service implementation. And I should mention, for the ROSC iteration of the tool, we did a full update of that. That's in the hard copy. And the website we have also has links to many of those resources. That's still being updated. We have most of that done. We're still working on updating that, but I'll refer you to that in a little bit when we talk about the website. But we thought the resource section was very important, because as you're looking at your quality improvement strategies, your strategic planning, when you identify something you want to do, you very quickly now have a resource to go to give you the best information to inform you about steps you can take and things you need to know. We really try to focus on practical information and free information as well. Okay, so we've talked about the survey, and we talked about the planning implementation guide. Now I want to talk about how the tool links to outcomes. Originally, we designed the tool to support outcomes described in the ROSC, as I mentioned. So the SAPT survey corresponds to the item analysis of the ROSC. However, as part of our policy academy and meetings with the leadership team, the team identified that some peers have historically had difficulties with the ROSC. And in fact, when we were doing our pilot studies, we also found that some of the service recipients had some difficulties, and it was really around the instruments designed. So what the team recommended that we move from using the ROSC as an outcome instrument to the recovery self-assessment, which is a survey that was created at Yale University and has been extensively used throughout Connecticut. And specifically 2 segments of that assessment, the person in recovery and the family member significant other version. Now, in doing kind of a cross-reference, we found that this RSA, this recovery self-assessment, closely corresponds to the domains of both the SAPT and the ROSC. So we're very comfortable in using that as our outcome tool. You know, essentially measuring the same things, but doing it in a way that's less confusing, clearer, just more efficient, just a better tool in terms of its application. So ultimately, achieving positive outcomes is really what the work is about. That's, you know, that this tool, everything, its prime function, its prime purpose is that we can achieve better outcomes. So the idea is that the SAPT, the self-assessment planning tool, helps agencies to establish policies and practices that are going to result in a positive recovery-oriented service outcome. By using the RSA, the recovery self-assessment, that informs agencies about the degree to which they've achieved those outcomes. So if you apply that together, if you take the SAPT and the RSA, they may be used to support a process for developing policies, program planning, staff development, outcome evaluation. It gives you a powerful basis for which to kind of move forward with all of these activities. And that's what we just said, just to reiterate. So, and what's important here when we, looking at using these 2 tools together, and if we use them at 6 to 12-month intervals, we have performance data from both the perspective of staff and person served. And that's very powerful. So, and it's especially powerful when we can identify areas where there are discrepancies between the perspectives of staff and person served. And that's especially useful when we're looking at establishing priorities for quality improvement. There are also areas that could be followed up on in focus groups or surveys. I think if you want to do consumer-based focus groups, it's a perfect mechanism to say if you identify a discrepancy to kind of drill down and find out exactly what's going on, and that can give you its tremendous power in looking at program or staff development. It can really make the difference in ensuring that you resolve those particular discrepancies. Okay, so that's a basic map, kind of a rundown of the tool. What I want to do now is just kind of go through the steps that you would take. So if you have this tool in hand, just kind of walk through, all right, what would it be like to take this and try to use this in our agency? What are the things we need to do? So I just want to quickly give you a rundown of what that would look like. So these are the steps, and I'll just talk a little bit about each of the steps in the process: selecting respondents, collecting that survey information from staff in each of the programs, then compiling program scores from those surveys, then compiling an agency score based on surveys, compiling all that information together, then recording comments or observations made by participants as part of the assessment process. Then a process of interpreting those findings, then establishing priorities and developing plans based on an agency-wide improvement plan, and then looking at how you could use the findings in the SAPT, and then if you're interested in using also the RSA during a 6 to 12-month interval to provide that complementary outcome information, and to make that a standard part of your CQI activities, then how you make recovery routine. So let's look at selecting respondents first. we're looking at, again, as I mentioned earlier, we want administrative staff, clinical supervisors, direct service staff, people with knowledge about how service is delivered in the agency and in specific programs within the agency. So the key is to select staff who understand that, who have some depth of understanding. And as I mentioned, important to be familiar with the SAPT, before you move forward to begin the process. And, just as an example, you might pick a senior supervisory and also some select direct line program staff from your case management program, your crisis unit, your inpatient unit, and your homeless outreach, and have each of them have responsibility for completing that survey. So we encourage also that as part of this process that the staff person facilitate a discussion with staff who are completing it to provide input into the score. But ideally you want, your supervisor and some key select staff to be involved in each of the programs. So that lead person then is responsible for collecting survey programs or surveys findings from the program, putting all the survey information together. So there are 50 items, 50 survey items total on a 4-point scale. So that means that a maximum score would be 200. And then you would also, as the way the survey is structured, you'll have scores that may also be viewed per domain. So with your administrative domain, you have 12 items with a maximum score of 48. Your treatment domains have 21 items with a maximum score of 84. And community integration domains have 17 items, maximum score of 68. So in addition to providing the numerical score for each item, the 1 to 4, it's helpful to record comments and observations made by participants as part of the assessment, because the numerical scores provide a way to view relative strengths and weaknesses for each program and for the agency. But the real power of the tool comes from exploring current service implementation through the lens of a recovery perspective. So it's, the number itself, it's helpful for understanding relatively where we are, but we need to go a little deeper and really exploring things, how we use that tool to get that recovery lens and get a deeper understanding of exactly what we're doing in our programs and how people who are our service recipients are experiencing those programs. Then you can basically start to compile a score, what program means, where you average all of the responses from all of the items within each program. So, for example, going back to our other program example about you could have a case management score of 140, your crisis unit score may have a total score of 125, again with 200 being ideal. Inpatient unit 135 and homeless outreach 165. So you can have each program within your agency maybe at a little bit of a different place, and also in different places specific to each of the domains. So when we look at the program domain scores, you prepare a score for each of the 3 domains, administration, treatment, and community support, by taking an average of the scores of the items under each of those domains. So, for example, if you have a case management score of 140, to go back to our example, that might mean administration is a 20, treatment a 71, community supports domain a 49. What's important here, and we do that for each of the programs, we're establishing a baseline against which we can then begin to monitor our progress. So now at the agency level, we can get an agency mean where we average all of the responses for all of the items within each of those programs. So for an agency domain score, we prepare a score for each of the domains, the administration, treatment, community support, by taking an average of the program domain scores. Actually very simple. And we want to record comments or observations. You know, it should provide a foundation for discussions about recovery orientation. So we want to track those kinds of things. And these are the kinds of observations that are really especially important to bring into the agency CQI meetings, your quality meetings, and to inform that kind of program planning, because that's where the depth of the tool comes in. Then, of course, we examine the findings, the scores of each domain program, the combined scores to establish a baseline of strengths and weaknesses for recovery services at the agency. So we're looking at both the numerical scores and qualitative findings to provide a picture of how the programs within the agency are implementing services. So, for example, if we go back to case management, after going through your survey items, after going through any comments, you may have determined your case management needs to increase family involvement. You might determine your crisis unit needs to better ensure that service recipients are involved with discharge planning, that your inpatient units need to work with maybe offering advanced directives to clients, something that maybe you're doing or not doing enough of. Or in an agency level, you might determine that you need to use a consumer-based outcome measure like the RSA to really make a difference. So these are all things that will pop out in terms of things that you might potentially be able to do to make a difference. And of course, then you need to establish priorities. So in addition to observations of agency practices, you could also be compared to objective evidence such as policy statement and clinical records. So you can begin to looking at other aspects of your operation from a more objective point of view to kind of take that to the next level. But, you know, as we look at priorities, I think what's really important, and this was true in our pilots and it's true in any kind of really program development, is to just have manageable priorities. You want to look at all the things you might want to do, but, you know, having that conversation about what's realistic, what's going to give us the biggest bang for our effort, all those things are really vital. And, you know, really basic, good strategic planning, you know, that's where the data you have now can really empower you, but it does require good strategic thinking and establishing priorities, understanding your resources, your needs, and you know, what can make the biggest difference in terms of what you want to achieve. Okay, and now using both the SAPT and the RSA together, again, it increases the power of what could be achieved. And again, highlighting the discrepancies as being a real key in having those discrepancies really being keys to things you might want to address in your CQI strategies. When I refer to things, well, what's going to give you the biggest bang for your effort, the most impact, this can really be helpful in determining what that is. And then making the this kind of assessment process, using this tool as a standard part of your continuous quality improvement process at the agency. This, in my mind, is one of the most critical pieces of all of this, because if it does not become part of what you do as part of your standard practice, it's not going to happen. Recovery will not happen. So it's saying that recovery is going to be a standard part of how you do business. It's a standard part of your quality improvement in the agency. So, and then it provides that structure and process for ongoing conversation, reflection, evaluation, and improvement. So, very important. And finally, you know, it's all about recovery becoming routine. So it changes in our practice and performance equals that change in culture that we're talking about. So our goal is to make recovery a routine part of how we do business, and it's really how a culture, how a system is truly transformed. And to that end, really, you can look at this agency data that we collect. They could also be compiled as part of regional or even statewide strategies if we start to compile it. And that's where using web-based methodology can be very powerful, because you're able to organize large amounts of data that can be quickly synthesized and produce reports about recovery orientation, again, at a regional level or even at a statewide level. Okay, and I did refer earlier to the SAPT website, and that is www.saptrecovery.org. It includes everything needed to implement this tool, as well as background information and a variety of resources. It has the survey, the planning and implementation guide. It includes studies that supported its development. They're all there, the pilot studies. There's links to the web-based SAPT and ROSC. We're going to need to change that to the RSA. Right now we still have the ROSC up there, but it's you can at least get it. If you go to the site and you hit the assessment link, you can see what it looks like there and how it kind of rolls up on the Qualtrics platform. There's also a blog we built into the website that's designed to promote partnership among consumers and other stakeholders. It's still there and active, and it can be easily engaged if we want to use that for that kind of purpose. And the Qualtrics, as I refer to, is the method we used. I don't want to go into detail on that for this call. I just want to let you know that that's an option, and it can be used to for setting up your survey and collecting the data and producing real-time reports. Very, very, very powerful tool. I was fortunate to work with someone here at the university who's really skilled with the platform, and if that's a direction an agency or even the state wanted to go in, has tremendous power in being able to use web-based methods such as this. And here's some screenshots to give you a sense of what it looks like. The survey that we used, the beginning of it. Here's the these are the administrative domain questions. And here are the questions for treatment and community integration. And here are some reports that came out of these are ROSC reports here, but gives you an idea of kind of real-time compilations and synthesis that occurs and the kind of reporting that it can do. Okay, with that said, as we come to the last segment for this afternoon, I wanted to talk about some keys to translating the recovery principles and this kind of ROSC vision that we've talked about into good practice, and also to look at some of the challenges that we can expect to face as we move forward with this initiative. I think some lessons that identifying agency priorities and establishing a manageable number of goals. It's pretty basic, but it's always good to remember and not to be overwhelmed. We get a lot of good data, but we need to, having clear priorities and a sense of what's going to give us the biggest bang for our efforts is very important. And also, focusing on strengths as well as weaknesses. Something like, give you an example, if rather than looking at, areas that are weak that you want to, they might be important, but you might determine that, we have a program that does really good person-centered planning. If we expand that, we can have a tremendous effect on how we do things in the agency, and we already have really what we need to do. We just need to do more of it. That's a good example of where sometimes it's more effective to take something you're doing well and build on it rather than necessarily always focusing on deficit areas. important to integrate recovery-oriented services with the CQI. It's vital, and I've already talked about that, but it's really very important, I think, for a tool to be successful and useful. Person-centered decision-making is a high priority no matter what. I think we found that it's the one area, if it isn't happening, you're not doing recovery-oriented services, so really want to highlight that. Again, I think the 6 to 12-month interval for repeating it is a good guide, and for both surveys, and we already mentioned the CQI, and that's a redo. Okay. Okay, and just a few comments about some common challenges, and I think this is just based on my pilots with this and my experience at recovery services going back to the early 1990s at this point, and I think these are just some challenges that we can anticipate and we ought to be cognizant of. And we'll start with number one, which is that recovery is a threat to the status quo, even still today. And evidence of that is that we're still today, if we look at our system, we're very highly invested in safety and acute care, keeping people safe and responding to acute conditions. So we have significant financial as well as emotional staff investment in the front-end services. So these, of course, are important, but it is also important to recognize that recovery-oriented services are still viewed in some circles as soft or frivolous, setting unrealistic expectations for individuals or seriously disabled, that we're setting up the seriously disabled for disappointment, or as viewing it as something that we get to after first engaging in the work of symptom management. So the ROSC activity, the ROSC initiative, offers a vision that's more inclusive of long-term support strategies, but it's important that we recognize that this vision is sometimes contrary to traditional ways that we've been doing business, and it's part of the things we're going to need to address. There's also a reluctance to give people with lived experience meaningful roles, and it's having people with lived experience as partners in this process is fundamental to what happens in a recovery-oriented program and system. And unfortunately, I think sometimes our beliefs about what's possible for folks with lived experience, they're based on snapshots of people at their worst. So we need to, we're not often cognizant, I think, of the gifts, the talents that could be brought to the table, and the fact that people do get better over time. So, there's also a need to bring peers into our process, and I guess, when we think about, when I've witnessed personally from bringing peers in, is that it's amazingly transformative to the agency itself. It's transformative for the people working in the agency, and it's transformative to the peers who are working in the agency, and it's transformative for the service recipients. So, but the key is creating the conditions, the structures, the supports to do it successfully, to do it in a way that's going to work. And unfortunately, it's something that's often been implemented in a way that hasn't worked well, and people look to that as evidence that, well, peer supports can't work. But we need to be aware of how we're implementing these kind of interventions, and if implemented properly, they indeed can make a tremendous difference on many different levels. And also that recovery is often addressed in specific programs rather than as an agency-wide approach. So for example, having a clubhouse or a rehab program, it's a great thing, but it doesn't mean that you really have an agency-wide recovery-oriented agency. So really that's why the SAPT looks at all the programs within the agency and the degree to which they are moving in that recovery direction. And of course, we want to make recovery a routine part of our quality improvement, as we've already mentioned a few times. But this is a challenge that's best addressed very simply by designating a staff person who has a role and a responsibility specific to the recovery services as part of their standard CQI activities. You know, you need that person who has that responsibility to ensure it's going to happen. Recovery is still often viewed as anti-medical model, and of course, understood properly, it's complementary to the medical model. And then, finally, there's the challenge of workforce challenges. The sometimes lack of training, low pay, high turnover, the need for coaching and supervision. And in a lot of ways, that's kind of the elephant in the room when we look at our system, because there's so much work we need to do there. But as this relates to recovery, I think that a recovery-oriented work culture is not only good for service recipients, but it's really also good for staff, because staff who work in partnership with clients and who are sharing a hopeful vision, they're much more likely to have a positive and fulfilling work experience. So, and that goes a long way toward really both recruiting and keeping good people that we need to have these programs be successful. Oh, and next actually is one more thing finally, is that there are system challenges where we have pockets of recovery interest at specific agencies, some more, some with very little. We have pockets of recovery interest even within agencies where we have particular programs, as I mentioned, and others that don't within an agency. And we have a history of not having a centralized vision and leadership at federal levels, state levels, local levels. And with ROSC now, we now have that vision and the leadership, and most importantly, we have an opportunity to be champions for this vision. So I think, you know, we have a wonderful opportunity here, and my hope is that the tool can help us in some way to see that vision gets realized. And to wrap up, with a quote about realizing the vision, and this is from Bill Anthony Bill was for a long time the director of the Center for Psychiatric Rehabilitation at Boston University, and I worked there back in the 90s, back in the day, and but Bill said that when he talked about the recovery vision, and he's one of the real early pioneers in moving this forward, but he said a vision's not reflective of what we're currently achieving, but what we hope for, what we dream of achieving. So visionary thinking does not raise unrealistic expectation. A vision begets not false promises, but a passion for what we're doing. So I think here now with ROSC, we have an opportunity to bring our passion and our skills to truly make a difference for individuals served in our system. So the ROSC initiative and the SAPT provide the structure to channel that passion into a community system of care that brings people with behavioral health disorders back to a life of dignity and full membership in our communities. And really that's what it's all about. So I wanted to just leave my contact information. I wanted to, thanks for your interest in recovery and for participating. Thanks again to Wes Evans at DCF for taking the lead in this ROSC initiative, keeping that recovery vision alive. And, you could feel free to contact me down the road. And I guess, Leanne, if we can take questions, if there are any questions, I'd be glad to field those now.
Wonderful, Jim. Thank you so much. Yes, we do have a couple of questions and a comment. So the first question relates to the Joint Commission for Accreditation and Certification. And the question is, does JCO know about this?
Well, not to my knowledge. So I can't really answer it. I would suspect not, but but I don't know.
Mm-hmm. And there was just a comment related to that, saying that it needs to be required. So related to, I suppose, JACO's credentials.
Oh, I'm sorry, I didn't catch it. It needs to be what?
That it needs to be required, and I'm assuming that means for JACO credentialing.
Oh, I see. Yeah. Well, you know, at this stage, we're looking at it as voluntary. You know, those are, you know, at a systems level, there's always decisions about at what point you want to require agencies to use the tool, use the instrument, produce reports, you know, in some formal way. And I think that, yeah, that will certainly contribute to participation significantly. But yeah, it's a very good suggestion.
And the other question is, do agencies use a common quality improvement tool now, or is that by individual agency?
Well, I think for the most part, agencies have their own process. You know, there may be some commonalities across them, but I'm not aware if they're using a standard tool for CQI. Mm-hmm. Yeah, I'm not really, so I can't really, I guess, answer that with any authority, but I think my best understanding is that there's a lot of variability across agencies in terms of how, and of course, you know, if you're working toward an accreditation like JACO or CARF, for example, that's going to be significantly, that's obviously going to inform your CQI activity if you're keeping those accreditations. And I would mention also that CARF, which is another accrediting body, is very much recovery oriented. You'd see many of the factors involved in this tool, in the SAPT and the RSA, reflected in the CARF reviews.
Thank you for that. And then there was another point made that's really a comment, and it says that they agree that it was a good point made that many find treatment plans as an administrative process and not something beneficial to the client. Treatment plans should be individual, customized. As long as you have an administrative policy that mandates an element of data collection, you automatically start a process that dictates compliance and takes away that element of customization, which is kind of a follow-up comment.
Well, yeah, that's a whole other discussion. It's a very interesting point and a very good point, and I think the key comes down to how, you know, we create structures and processes, but the person's making the point that, you know, that can stifle individuality if it's not implemented properly. So that comes down to how we do person-centered planning in a truly efficient and effective way. And actually, there's an excellent book by Neil Adams on person-centered treatment planning that addresses that very question in detail. In fact, that's like the heart of the book, is how do you do and how you integrate good person-centered planning under current, you know, fiscal and administrative structures, and how you use those structures to, you know, kind of support good planning that is truly individualized, as that person pointed out. But, and in my view, how we do that is probably, I would say actually maybe the most important, at least on a clinical level, thing that we must do if we're serious about effective recovery-oriented services. Without the person behind the wheel, getting behind the wheel of that plan, not just in a perfunctory way, but truly in a way that's going to involve them in their care in a deeper way, and we develop that kind of partnership between the client and the you know, the staff at the agency, then we end up going through the motions in a lot of ways, and that's exactly what we want to move away from.
And Jim, what was the name of that book?
Well, the name of the book, here, I know I have it here. There it is. Great, very handy. It's called Treatment Planning of Person-Centered Care, The Road to Mental Health and Addiction Recovery by Neil Adams and Diane Greider. That's Neil, N-E-A-L Adams. Outstanding. I highly recommend it.
Okay, thank you for that.
Sure.
Now that concludes our questions and answers and our comments for today. I'm going to take control back of the presentation now, and we're going to share with the attendees just some follow-up information as we begin to wrap up today's presentation. First of all, Jim, thank you so much. We appreciate you taking time to share with us today, to share your expertise. It's been very interesting, and we just really appreciate that. Thank you for sharing that website, that saptrecovery.org, and FATA will be adding a link to that on our resource center as well. So there will be, yet another way to locate those resources through our resource center. I also just wanted to remind all of the participants that when you exit the event today, when I close it down, your browser will take you to an evaluation form on our FATA website. But if you have any difficulty at all with getting access to that evaluation form, you'll get another chance because the system through WebEx will automatically send an email to you a little bit later today, and that email will have embedded in it another link to the evaluation. So you'll get another chance to complete the evaluation. And of course, that's important because we need you to complete the evaluation. And if you attended today's entire presentation, we'll be issuing you a certificate of attendance. And for those of you who are Florida healthcare practitioners, we'll be reporting your hours to CE Broker. And again, I'd like to thank all of you, all of our attendees, for taking time to join us today to hear about this important topic. We always appreciate your participation. And thanks also especially to the Florida Department of Children and Families, Office of Substance Abuse and Mental Health for their funding for today. So please do have a great rest of your day, and hold on now for the evaluation. Thank you so much, and goodbye. And goodbye, Jim. Thank you.
All right. Thank you. Take care, everybody.